Usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Right, like we want something we can easily point to.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, there's the problem. It's visible. It's clean.
It's totally categorized. We want our medical interventions to be something we can hold in our hands, right? A pill, a scalpel, a cast.
Yeah. But then you step into the world of using light as medicine, and suddenly that gentle, invisible wave we use just to, see our way down the hallway is, well, it's weaponized.
Weaponized is a good word for it.
We're looking at a clinical landscape where the exact same fundamental element that warms your face on a sunny day is being harnessed to literally vaporize human tissue.
It is the absolute definition of controlled destruction. I mean, the precision is astonishing, but the sheer raw power required to make that light do physical work on biology it's staggering when you break down the mechanics.
You're listening to The Deep Dive. And if you are someone who is intensely curious, who loves those aha moments of understanding how the world actually works, but you don't want to drown in a sea of dense medical jargon, you are in the exact right place.
We have a really fascinating stack of sources to work through today.
We do. We are looking at a mix of NHS patient leaflets, highly detailed clinical safety guidelines, specifically the GCCP and CPSA standards, and various cosmetic clinic protocols.
Some really dense material, but so interesting.
Right. And our mission today is to completely demystify medical lasers. We're going to explore the physics of how concentrated light can erase trauma scars, how it can clear up cloudy vision from inside your eyeball, and the almost sci-fi safety matrix operating behind the scenes to keep patients safe. So, okay, let's unpack this.
Well, what we're really looking at today is the intersection of quantum physics and human biology. It is the realization that by manipulating the exact wavelength of light, doctors can perform highly targeted medical magic. We aren't cutting with steel anymore. We're cutting, heating, and shattering with pure energy.
Let's start with the word itself, actually, because I think a lot of people forget that laser is actually an acronym.
Oh, absolutely.
It stands for light amplification by stimulated emission of radiation, which sounds incredibly intimidating.
It sounds like the warning label on a nuclear reactor, honestly.
Right.
But it tells you exactly, mechanically, what the machine is doing. It's taking light, stimulating it to emit a specific kind of radiation, and we mean electromagnetic energy here, not the radioactive kind, and amplifying it.
But what does stimulated emission actually look like? Like if I crack open one of these machines, how is it turning regular light into a medical tool?
Okay, so picture a tube with mirrors on both ends.
Okay, got it.
Inside that tube is a medium, so maybe a gas, a liquid dye, or a solid crystal. You pump a massive amount of electrical energy into that tube. That energy hits the atoms of the medium and excites them.
It hikes them up.
Exactly. An electron in the atom jumps up to a higher energy level. But it can't stay there, right? So it falls back down. And when it falls, it releases a tiny packet of light energy called a photon.
So it spits out a spark of light.
Right. But here's the trick. That photon bounces off the mirror at the end of the tube, flies back through the medium, and hits another atom that's already excited.
Oh, okay.
That collision forces the second atom to release a photon that is an exact identical clone of the first one. Same wavelength, same direction.
Wow, so now you have two.
Yes. They bounce off the other mirror, hit more atoms and create 4, then 8, then millions. They are cascading back and forth between those mirrors, amplifying into an incredibly intense beam of cloned light until it finally shoots out through a tiny opening in one of the mirrors.
It's like a microscopic hall of mirrors continuously cloning energy until it reaches a boiling point.
That's a great way to put it.
I mean, the best way I can think to visualize the end result is comparing it to a standard light bulb in your house.
Right.
A regular light bulb is essentially a sprinkler. It's throwing a massive rainbow of colors, all different wavelengths, in absolutely every direction to light up a room. But a laser is a sniper rifle.
Exactly.
It is a single color, a very specific wavelength traveling in one tightly focused direction.
And the clinical why behind that sniper rifle is the foundation of all laser medicine.
Why go through all the trouble, right?
Yeah, why go through the trouble of cloning photons in a mirrored tube? Because different wavelengths of light target entirely different structures inside the human body. The medium inside the tube dictates the wavelength, and the wavelength dictates the target.
So the sources list a few of these mediums.
Yes, you have gas lasers that use carbon dioxide or argon,
Hmm.
and you have solid lasers that use synthetic crystals, like an ND.YAG crystal, which is a highly engineered crystal doped with the rare earth element neodymium.
So you swap out the crystal or the gas, you change the color of the beam, and you change what part of the human body you're basically hunting.
It is entirely about target acquisition. So let's look at vascular lasers.
Okay.
These are designed specifically to hunt down hemoglobin. Hemoglobin is the protein inside your red blood cells that carries oxygen, and it's what gives blood its deep red color.
Right.
The laser is tuned to a wavelength that ignores human skin, ignores water, ignores fat. It passes right through the top layers of your tissue as if they were completely invisible. But the millisecond it hits that red hemoglobin, the light energy converts into pure thermal energy.
So it literally heats up the blood.
It heats it up so fast that the blood vessel essentially cooks. The walls of the vein collapse and clot, or simply rupture entirely, which completely cuts off the blood flow. The visible vein on the surface of your leg or your face just instantly disappears.
That is wild. And then you have pigment lasers, which operate on a totally different wavelength.
Right.
They ignore the blood and hunt for brown or black colors,
Mhm.
like natural melanin in an age spot, or artificial ink in a tattoo. But if they aren't boiling the target like a vascular laser, what are they doing to the ink?
They deliver energy so incredibly fast. We are talking about picoseconds or trillionths of a second that the pigment doesn't even have time to heat up and boil.
Yeah, trillions of this.
Yeah, insanely fast. Instead, the sudden influx of energy creates a microscopic shock wave. It actually vibrates the pigment so violently that it shatters into microscopic fragments.
Yeah.
It's basically using a light-induced acoustic wave to smash a boulder of ink into sand. Once it's sand, your body's natural immune system, specifically scavenger cells called macrophages, can just sweep the debris away over the next few weeks.
I have to pause and push back on this, though. If the laser is literally creating acoustic shock waves to blow up pigment under the skin or boiling blood vessels until they rupture, what does that actually look like on the human body right after it happens?
It's intense.
I mean, if you boil a vein under my skin, my leg is just going to look like it has a mild sunburn.
No, the immediate physical reaction is intensely dramatic. When a pigment laser shatters ink or melanin, that rapid expansion of energy creates a sudden release of microscopic gas bubbles just under the surface of the skin.
Oh, wow.
This creates what the medical guys call a white frosting effect. The skin over the tattoo, or the age spot, literally turns stark, chalky white and raised for about 10 to 20 minutes while those gas bubbles dissipate.
It looks like the skin has been flash frozen. And what about for the vascular lasers destroying the blood vessels?
For those, especially with something called a pulse dye laser, you are intentionally rupturing a tiny blood vessel. So the blood leaks out under the skin. You get something called purpura.
A purpura.
It is an intense, dark, purple, almost black bruise in the exact shape of the circular laser pulse. And that bruising lasts for 10 to 14 days.
Oh, my gosh.
You walk out of the clinic looking like you've been struck by a tiny, perfectly round paintball. It looks quite severe before the body finally breaks down that leaked blood and clears it away.
Moving from hunting specific colors to altering the literal foundation of the body is a huge leap. Let's talk about skin resurfacing. This is where we stop targeting red blood or black ink and start targeting the actual structure of the skin itself to treat trauma scars, severe burn scars, and deep wrinkles.
Yes, this brings us to an entirely different class called ablative lasers. The most common ones are carbon dioxide or CO2 lasers and erbium lasers. Unlike the pigment or vascular lasers, ablative lasers don't care about color at all. They hunt for water.
But human skin is essentially a giant sponge. I mean, it's mostly water.
Which is exactly the point. Because the skin is packed with water, when an ablative laser hits the surface, the water molecules inside the skin cells absorb that immense energy instantly.
Right.
The result is that the tissue reaches boiling point in a fraction of a second. It literally flashes into steam. The skin is vaporized, turning from a solid biological material into a plume of smoke.
It's basically a controlled forest fire for your face or your arm. You're creating deliberate, highly controlled micro-injuries, so that vaporization is the ablation, to force the body's immune system to completely freak out.
That's essentially it.
The body detects this massive acute burn and goes into overdrive to heal it. And in doing so, it creates a massive surge of fresh, perfectly structured collagen to replace the scar tissue that was just vaporized.
The mechanism relies entirely on tricking the body's wound healing cascade. But the geometry of how you deliver that fire matters immensely. The clinical guides break this down into two specific methods, focal and fractional.
Right, saw that.
Focal ablation is the traditional, older method. The laser beam destroys a discrete, solid block of tissue. You just paint the beam over a raised scar until it's gone. It's highly effective, but it leaves an entirely open, weeping wound.
You essentially have a second-degree burn. The sources say patients have to use mupirocin, which is the heavy-duty prescription antibiotic ointment, keep it dressed, and deal with severe oozing and bleeding for days just to stave off infection.
Yeah, the downtime and risk of scarring from the treatment itself were huge problems. But then physics gave us fractional ablation.
Okay, how does that work?
If focal ablation is clear-cutting the forest, fractional ablation is more like aerating a lawn. Instead of one solid beam of light, the machine splits the laser into a grid of dozens of tiny, equally spaced microscopic beams.
Oh, that makes sense.
It punches thousands of microscopic, vaporized channels deep into the skin, but it leaves healthy, untouched skin completely surrounding each of those tiny holes.
It's basically a cheat code for healing. Because that healthy skin is still there,
Yeah.
Holding the structure together, the healing time is massively reduced.
Exactly.
The healthy cells just quickly multiply and bridge the microscopic gaps. The sources mention this is frequently used for thick, inflamed scar tissue, like from a bad burn, where you want to break up the tight scar bands without creating another massive open wound.
What's fascinating here is that those microscopic vaporized channels serve a dual purpose. Yes, they trigger the collagen remodeling, but because you've essentially drilled thousands of tiny open wells deep into the dermis, doctors can use those channels to deliver topical medications.
Oh, wow.
Yeah. For a burn scar, a doctor can apply a strong liquid steroid immediately after firing the laser. The steroid sinks deep down into those channels, directly into the inflamed tissue, in a way that simply wouldn't be possible if they just rubbed it on intact skin. It's called laser-assisted drug delivery.
Okay, so vaporizing skin on the surface to trick the immune system is amazing. But how does this technology adapt when the problem isn't on the surface? What happens when the target you need to vaporize is inside a vital, highly sensitive, fully enclosed organ, like the human eye?
This is where the absolute millimeter precision of these wavelengths really shines. We are looking at a procedure called a Weige laser capsulotomy. It is an incredibly common follow-up procedure for people who have had cataract surgery.
It set the stage for this. During a standard cataract surgery, your natural lens has gotten cloudy over the decades. The surgeon goes in, removes that cloudy lens, and puts a clear artificial plastic lens in its place.
Right.
But that new plastic lens is seated inside a very thin natural membrane called the capsule. It's basically like a shrink-wrap bag holding the lens. Fast forward a few years, and that natural capsule itself can start to naturally thicken and turn cloudy, like frosted glass, ruining your vision all over again.
And going back into the eye surgically, with physical tools to scrape that membrane clean, carries massive infection risks. So they use the Weige laser.
Because it doesn't need to cut the eye open.
Exactly. Because of its specific wavelength, the beam passes completely harmlessly through the clear cornea at the front of your eye, passes perfectly harmlessly through the artificial plastic lens, and dumps all of its thermal energy precisely onto that cloudy membrane sitting a fraction of a millimeter behind it.
Reading the patient experience from the Wrightington Wigington Lee Hospital leaflet was wild, because it sounds like a sci-fi abduction sequence, but it is a totally routine outpatient appointment.
It really is routine.
First of all, there are no needles. It's completely painless. You walk in, sit down, and place your chin on a mechanical rest. The doctor puts some numbing anesthetic drops in your eye, and then they physically place a special heavy glass contact lens directly onto your eyeball.
Right.
This physically holds your eyelid open so you can't blink, and it acts as a magnifying glass to help the doctor focus the laser beam deep into the eye.
So you are immobilized, staring straight ahead, and then the laser fires. But you don't feel heat. You just hear a distinct clicking noise from the machine, and you see incredibly bright flashes of light.
Just flashes and click.
Yeah. What the laser is doing with each click is punching a microscopic hole in that cloudy membrane. The doctor fires a series of these pulses in a circular dotted line pattern. When the circle is complete, the center of that cloudy membrane just drops away like a tiny trapdoor.
Oh, no.
It instantly creates a perfectly clear window for light to pass through to your retina.
And it takes maybe 3 minutes. You walk in, sit down, click, click, clicks, trapdoor drops, and you walk out. but your vision immediately afterward is completely chaotic.
Yeah, that part is disorienting.
The sources say you are temporarily blind or severely dazzled just from the sheer intensity of the laser flashes. And as your vision recovers over the next 5 to 10 minutes, the world slowly fades back in through a series of strange, washed-out colors.
It is a profound sensory overload. But as routine as this procedure is, exploring the risks highlights exactly what physical forces are operating inside the eyeball. You are firing pure energy millimeters away from vital structures.
Yeah, the risk that made me physically wince reading the clinical guides was lens pitting.
Oh, yeah.
Because the laser is focusing its heat literally right behind the artificial plastic implant. The doctor's focus is off by a hair. The laser will hit the plastic instead of the membrane. It will instantly melt a tiny crater or a pit into the permanent artificial lens.
Which is permanent. It usually doesn't affect vision unless it happens dead in the center of the visual field, but it absolutely proves the violent power of the beam. Another highly common physical side effect is floaters.
Right.
Patients report seeing dark cobwebs or swarms of black dots drifting across their vision for weeks after the procedure.
And those cobwebs aren't an optical illusion or a trick of the light. They are the actual physical pieces of the biological membrane you just blasted apart.
Exactly.
It's cellular debris floating around in the fluid of your eyeball until the body's internal systems slowly reabsorb them.
And that debris is harmless, but the energy wave that created it is not always benign. The rapid vaporization of that tissue creates a microscopic shock wave inside the fluid of the eye. In rare cases, that acoustic shock wave can travel to the back of the eye and hit the retina.
Oh.
The force can literally tear the retina away from the back wall of the eye, causing a retinal detachment. Patients are strictly warned to monitor their vision for sudden flashing lights in their periphery or the sensation of a dark physical curtain being pulled down over their field of view. It's a catastrophic medical emergency that requires immediate surgical intervention.
When you realize that a microscopic shock wave from a light beam can detach a retina, or that a miscalibrated wavelength can cause permanent third-degree burns, you suddenly understand why the regulatory red tape surrounding these machines is so overwhelmingly thick.
Oh,
You
definitely.
can't just plug one of these in and start zapping. There is a hidden matrix of safety and rules operating behind the scenes.
The clinical governance is intense. The Cosmetic Practice Standards Authority, the CPSA, and the Joint Council for Cosmetic Practitioners, the JCCP, have laid out incredibly strict frameworks. You are handing practitioners a device capable of unimaginable damage if the physics are misunderstood.
Just looking at the patient preparation rules before you even sit in the chair for a skin laser was mind-blowing. The list of absolute don'ts is massive. No makeup, obviously, no aftershave. But the biggest, strictest red flag across all the cosmetic clinic guides, absolutely no fake tan for 4 weeks prior to treatment.
If we think back to how pigment lasers hunt, the physics behind the fake tan rule makes perfect sense.
Okay, how so?
Lasers rely on a concept called the contrast ratio. A pigment laser is hunting for dark melanin against a background of lighter skin. It is calibrated to pass through the lighter epidermis and dump its energy into the dark spot deeper down. If you coat your epidermis in fake tan, you destroy that contrast ratio.
So the surface of your skin is now just as dark as the target.
Exactly. So the laser gets confused. As soon as the beam hits the artificially darkened surface of your skin, it thinks it has found the target. It instantaneously dumps all of its thermal energy onto your epidermis instead of traveling deeper.
Oh, that sounds bad.
It causes immediate, severe blistering burns and often permanently destroys the melanocytes, leaving you with permanent white patches in the exact shape of the laser pulse.
It's essentially a friendly fire incident on your own skin.
Hmm.
Then there are the medication red flags. If you
Mhm.
take blood thinners like warfarin or daily aspirin, that has to be strictly managed and often stopped. Because if a vascular laser ruptures a vein and your blood can't clot, you will have massive internal bruising.
Right.
But the craziest rule to me was the hard stop around strong acne medications, specifically oral retinoids like Roaccutane.
The Roaccutane rule is an absolute non-negotiable hard stop in any reputable laser clinic. Roaccutane is a powerful drug that fundamentally alters your sebaceous glands, so the oil glands in your skin, and rewires how your skin heals at a cellular level.
Wow.
If a patient is taking an oral retinoid, they are mandated to stop taking it a full 6 months before any ablative laser treatment.
6 months. Just to wait for the drug to fully clear the tissue. Because if you fire a CO2 laser and vaporize the skin of someone currently influenced by Roaccutane, Their body simply will not initiate that collagen healing cascade we talked about earlier.
Exactly.
The skin essentially forgets how to heal the burn. You risk severe, permanent, atypical scarring that looks almost like a melted wax effect.
So the patient has to prepare their biology, but the clinics have even stricter governance over the operators. Under the JCCP standards, clinics must have a designated laser protection supervisor on site, and they often consult with an external physicist known as a laser protection advisor.
Wow, they actually bring in physicists.
Yeah, and the clinical assessment of the tissue before turning the machine on is rigorous. Take the treatment of a simple pigmented mole, for instance. Before a practitioner ever fires a laser at a dark spot, they are mandated to rigorously apply a dermatology ABCDE rule.
Asymmetry, borders, color, diameter evolving. Basically checking if the spot looks suspiciously like cancer.
Right, because if a practitioner is reckless, mistakes a melanoma, which is a deadly spreading skin cancer, for a simple sunspot, and blasts it with a pigment laser, the results are catastrophic.
What happens?
The laser will shatter the melanin, successfully removing the visible brown pigment from the surface of the skin. They have effectively made the cancer invisible to the naked eye. But the cancer cells are still alive, silently metastasizing and spreading deeper into the body.
Oh my God.
Yeah, erasing the visual warning sign delays the oncology diagnosis, and that delay can easily be fatal.
That is terrifying. It really underscores that you aren't just erasing a cosmetic blemish, you're altering biological indicators.
Exactly.
I also noticed a heavy emphasis on psychological safeguards in the documentation. Mandatory cooling-off periods, for example. The JCCP strongly advises a 2 to 5 day cooling-off period after a consultation before any ablative treatment can physically happen. You cannot just walk in off the street feeling insecure about a scar and impulse buy a laser resurfacing.
They want to ensure patients truly, soberly understand the physiological downtime. If your face is going to be red, crusting, oozing serum, and requiring constant ointment for 2 weeks, that has a massive psychological impact.
You're sure?
You need time to process that reality and arrange your life and work around it. Furthermore, pre-treatment clinical photography is absolutely mandatory across the board. It documents the baseline state of the tissue, not just for a clinic's marketing portfolio, but for strict clinical accountability if an adverse physical reaction occurs.
And to wrap up this safety matrix, we have to talk about the physical gear protecting the patient in the room. It's not just handing the patient a pair of cheap plastic sunglasses. When doctors are using ablative lasers anywhere near the eye, say, to vaporize and tighten the loose skin of the eyelid, the safety gear is basically medieval.
It really is.
They actually put numbing anesthetic drops directly onto your eyeball, and then they physically slide a protective solid metal or a thick plastic shield entirely underneath your eyelid.
It acts like a literal metal spoon resting directly over your eyeball. It physically blocks the laser beam. If the practitioner's hand slips or the patient twitches, the laser hits the metal shield instead of penetrating through the ultra-thin eyelid skin and instantly blinding the patient.
That just sounds awful.
It is deeply uncomfortable to have metal resting on your eye, but when you are firing, vaporizing lasers millimeters from the optic nerve, it is absolutely essential.
We have covered a massive amount of ground today. We've journeyed from understanding how photons bouncing in a mirrored tube create a microscopic medical sniper to the controlled forest fires of vaporizing trauma scars.
A lot of physics.
Yeah, and we've talked about punching microscopic holes in cloudy membranes inside the eye and the massive, almost overwhelming web of safety protocols, from fake tan rules to metal eye shields designed to keep us intact while all this raw energy is flying around.
And this matters to you for a highly practical reason. Whether you are considering a cosmetic treatment to smooth out an old injury, prepping for an eye procedure for a relative, or just living in a modern world increasingly filled with high-tech devices, understanding the actual mechanics is empowering.
Absolutely.
When you understand how energy interacts with human biology at a fundamental cellular level, you are equipped to ask the right questions. You can separate actual rigorous medical science from flashy clinic marketing hype.
So what does this all mean? I want to leave you with a final thought to mull over. We spend our entire lives bathed in light. We think of it purely as a medium, a benign way to see the world around us. But when you realize that this exact same element, just organized slightly differently, has the physical mass and raw power to vaporize human tissue, explode artificial ink, or permanently alter our biology, it makes you look at a sunbeam and wonder, what other invisible everyday forces around us are just waiting to be harnessed?